person for the Congress, but hopefully I can share with you my anatomic insight and give you an idea of, in this instance, the anatomy of the mitral valve. So what I'm going to discuss with you is the relevant anatomic features, and I'm going to do that in terms of the valvar complex. Then I'm going to discuss with you the significant relationships of the valvar components to the atrioventricular junction, the coronary arteries, the conduction system, and then very briefly, I'll take you through the relationship of the normal anatomy to congenital malformations. So let's get started with the valvar complex. And it was as long ago as 1972, as you see, that Joe Perloff introduced this notion, along with Bill Roberts, that we should be analyzing the valve in terms of its components as a complex. So what are those components? Well, I'm going to introduce the first part as the junction. But way back in 1972, Perloff and Roberts considered this to be the annulus. And I'll explain to you why now it's better to consider it in terms of a junction. Then we're going to look at the leaflets, the way they are supported, the tendinous cords, and of course the support offered to the cords themselves, the papillary muscles. So pictures are worth thousands of words. So this is what the valvar complex looks like when you observe it in the parasternal long axis equivalent. There we see the junction supporting the leaflets, in turn supported by the tendinous cords, the papillary muscles, and then the papillary muscles themselves cushioned by the trabeculations which attach them to the ventricular wall. So let's look at each of these components in turn. And let's start off with the junction. Well, significantly, the junction has two parts. The superior part, adjacent to the aortic root, is fibrous. It is the inferior part that is myocardial, and that is why it is better now to consider it as a junction. But let's look at that in a little more detail. And if we look at that anterior part, and here I'm using a computed tomographic image lent to me by Tony Levarchek from the Medical University of South Carolina in the USA. And there you see that fibrous hinge of the mitral valve, and it is in fibrous continuity with the aortic root. It is anchored at each side by the fibrous trigones, but significantly, the right fibrous trigone does not reach the septum, and between the two is the inferoseptal recess. And we'll talk about that also when we consider the aortic root. But let me show you how that area of continuity between the aortic leaflet of the mitral valve, the non-coronary leaflet of the aortic valve, is separated by the inferoseptal recess from the septum, in particular, the membranous septum, the interleaflet triangle. And we're going to look at those components much more when we get down to consider the aortic root. But let's turn our attention now to the mural junction, again beautifully seen in the image lent to me, Tony Levarchek. There you see the hinge of the mural leaflet at the atrioventricular junction. And in places along that junction, we do indeed find a thick fibrous support, which we can call an annulus, but elsewhere in the same junction, we can find a shelf rather than a cord. And this has become somewhat controversial because this finding is ubiquitous. But nowadays it's achieved attention as disjunction. Whether it is significant still has to be established, but believe me, if you look in detail, you can find some degree of disjunction in every mitral valve. We don't have time to go into that controversy, so let's move on and look at the leaflets. And they are supported by the junctions. So one is mural or posterior. It is shallow, as I'll show you shortly. The other one we've already discussed is in fibrous continuity with the leaflets of the aortic valve. So that's why I prefer to call it the aortic leaflet. And it guards 1/3 of the valvar orifice, but is much deeper. And we see that beautifully when I show you this open mitral valvar orifice. And there now you see the mural leaflet, you see how long it is, but also how shallow it is. Contrast that with the aortic leaflet, which guards only 1/3 of the circumference of the orifice, but has much greater depth, so that the surface area of the two leaflets is more or less the same. Now, when we think of anything that has two moving parts, there is but a solitary zone of apposition between them. But I'm sure most of you still recognize the so-called commissures, but they are no more than the ends of the solitary zone of apposition. And we can see that if we draw the valve in its closed position. So there is the primary zone of apposition, but there are slits in the mural leaflet. And that permits us to recognize what are known as the scallops. I've called them here the mural scallops. I'm sure you call them the posterior scallops. They abut against the opposite parts of the aortic leaflet, and we can name the scallops and the opposite parts of the aortic leaflet as numbers 1, 2, and 3. But we then need to remember that at the ends of the zone of apposition, we have the commissural leaflets. So when we open the valve, we can see the support provided by the tendinous cords, which of course arise from the papillary muscles. And each papillary muscle supports both of the leaflets through the tendinous cords. One of those cords is particularly prominent, and we call that the commissural cord. But note that the commissural cord does not extend all the way to the junction, because we have the area made up by the commissural leaflets. And there are the ends of the solitary zone of apposition, which I'm sure you call commissures. But equally important, all the ends of the leaflets in the normal valve are supported by tendinous cords. So these are the free edge cords. If we turn round the aortic leaflet, we can see other important cords, which are the strut cords. And then if we look under the mural leaflet, we can find basal cords with their own papillary muscles. So when we consider the tendinous cords, I think it's sufficient to describe free edge cords, strut cords, and basal cords. And they are supported by the papillary muscles. Now, how should we describe the papillary muscles? I'm sure many of you still consider these to be anterior, and posterior, but this is not the case. Nowadays, we need to describe the components in attitudinal fashion. And so the muscles, in fact, are produced antero-inferiorly and supero-laterally. And we can see that if I show you this dissection that I made by cutting the heart, the parietal wall away and looking it from the back. So there you see one of the muscles which is inferior, but is in front of the lateral or the superior leaflet. So the superior leaflet is posterior, the inferior leaflet is anterior. If you have any doubt, you can look again now at the computed tomograms, because now we have a cube that shows you the proper relationships. So you see that one of the leaflets is inferior and anterior, the other leaflet, the other papillary muscle rather, superior and lateral. And remember, they are separated from the septum by the inferoseptal recess. So there we have the components of the valve. So what about their relationships? Well, the relationships, two are particularly important: the coronary arteries, the atrioventricular conduction system. Quite some time ago now, I worked with a group in Israel, and we showed the relationship of the coronary arteries to the atrioventricular junctions. And you can see that when the right coronary artery is dominant, its termination is quite some way away from the left atrioventricular junction, about 1.5 centimeters in this reconstruction. However, when it is the left coronary artery, in particular the circumflex artery that is dominant, then the artery is much closer to the junction, and in some circumstances, as you see here, it can come within 3 millimeters of the hinge of the mural leaflet of the mitral valve. So it's particularly important to distinguish whether the right coronary or the left coronary is the dominant coronary artery. If we look down on the junction as viewed by the surgeon, in this instance having opened through the dome of the left atrium, avoiding the sinus node, we can then see those important relationships. The atrioventricular node is in the atrial septum, adjacent to the so-called central fibrous body. But then, running around the mural junction, we have the coronary sinus, in this instance shown in company with the dominant right coronary artery. But don't forget the significance of the circumflex artery, because when it is dominant, it is going to be much closer to the mural atrioventricular junction. So there we have the relationships. Let us now briefly try to put that into the context of the valvar complex and malformations of the mitral valve. You'll not be surprised to know that on occasion all components of the valvar complex can be malformed. But we can also split up the malformations in terms of those that involve the junction, those that primarily involve the leaflets and the tendinous cords, and then those that concentrate upon the papillary muscles. But let's first look at global involvement. And here's a picture of a globally malformed mitral valve seen from the back, having cut across the left atrioventricular junction. The junction itself is hypoplastic. You will see that the leaflets are dysplastic. The tendinous cords are thickened, blocking those intercordal spaces, and the papillary muscles are fibroelastotic. And this, of course, is what happens to the mitral valve in the setting of hypoplastic left heart syndrome when we have mitral stenosis. The valve itself is much more miniaturized when we have mitral atresia, and oftentimes you see very little of it. But when we have mitral stenosis in the setting of the hypoplastic left heart syndrome, then this is the typical feature associated with the fibroelastosis, reflecting the flow of blood into and out of the left ventricle. So let's now look at malformations of the specific components of the valve, and the junction, on occasion, can be absent, or it can be imperforate. The junction can be dilated, but this is rare in terms of the mitral valve itself, and we have to distinguish that from what we see in the setting of discordant atrioventricular connections, because then the morphologically tricuspid valve oftentimes is dilated and regurgitant, but it is the left atrioventricular junction that is being guarded. However, the valve is a tricuspid valve, and we'll be discussing that shortly in the setting of Ebstein's malformation when we specifically consider the tricuspid valve. And we must also distinguish between involvement of the mitral valve itself as opposed to the left atrioventricular valve in the setting of atrioventricular septal defect. You all know how frequently the left valve can be abnormal when we have an atrioventricular septal defect, but I hope we all recognize by now that when the atrioventricular septum is deficient, the left component of the valve is no longer mitral valve, is no longer a mitral entity, but is trifoliate. But let's move on and let's look at malformation of the leaflets and the tendinous cords. And here we must distinguish the isolated cleft, which is a true cleft. Again, distinguish that from the zone of apposition between the bridging leaflets we see in the setting of atrioventricular septal defect. We must recognize straddling and overriding of the valve, along with its dual orifice, but most importantly, the prolapsing valve. So here you see a very nice picture of the isolated cleft. In this instance, it's associated with a ventricular septal defect, but that shows us particularly well that when we have an isolated cleft, the cleft is pointing into the outflow tract of the left ventricle. And this is quite different from the location of the zone of apposition we see in the setting of atrioventricular septal defect, because that zone, of course, is pointing directly at the septum. So we need to distinguish the isolated cleft from the zone of apposition. Here you see a very nice picture of the straddling and overriding mitral valve. There again, it's going through a ventricular septal defect. And this is what we typically see in the Tausig-Bing malformation, either when we have transposition with a subpulmonary defect or when we have double outlet right ventricle and the interventricular communication is opening into the right ventricle beneath the pulmonary trunk. And very nicely, we see this straddling, which can be a significant problem for the surgeon in the setting of the Tausig-Bing malformation. Here I'm showing you dual orifice. Note that there is a connecting tongue between the aortic and the mural leaflet, and it is that tongue that separates the two orifices. Again, this is a mitral valve, and probably we see dual orifices more frequently in the trifoliate valve we see in the setting of atrioventricular septal defect. But as you see, we can also have dual orifices with an abnormal mitral valve. But look here at prolapse. Prolapsing here of the middle scallop associated with inadequate caudal support and elongation of the few tendinous cords that support the prolapsed leaflet. Whether this is associated with disjunction still has to be determined, and it could well be that when the valve prolapses, the disjunction is the consequence of prolapse rather than the cause. This still has to be established. So let's finish by looking at malformations of the papillary muscles. And here we need to take note of the arcade or hammock lesion and the parachute lesion. So here you see the arcade lesion, and there is fusion of the papillary muscles along the leading edge of the leaflets, along with obliteration of the intercaudal spaces. And this is going to produce severe stenosis. But we can also have stenosis produced by the parachute lesion, irrespective of whether that is the consequence of fusion of the papillary muscles, thickening of the tendinous cords, or when tendinous cords all move down to one papillary muscle in absence here of the superolateral muscle. So there we have it. I hope you will now appreciate that the mitral valve is a complex, and when it is malformed, all components of that complex can themselves be malformed in isolation or as a combination, which points again to the importance of analyzing the valves in terms of the complex. So thank you all for permitting me to join you, and I hope this leads you on now to more detailed discussions of the mitral valve.
Thank you, Professor Anderson. And now I would like to invite Dr.